and rotate your phone. It says can't turn your phone while recording.
Right.
So I'm good.
You just leave it like that.
Good afternoon. I'd like to welcome everyone to Facebook Live at Concord Orthopaedics. I'm Jeff Wiley.
You have to turn it the other way. It's got to be up and down.
Little snafu here on our audio visual here as we get it set up. And I'd like to welcome you to Facebook Live at Concord Orthopaedics. This is our 5th installment that we're bringing to you from our office today. Today's May 1st. Happy spring, hopefully, everybody, although nobody would notice that outside with another cold, rainy day. So this is the 5th series. Partners Dr. Baselli, Dr. Levy, Dr. Dion, and Dr. Casey have previously visited with you all, and I'm pleased and happy to visit with you today. We're in the midst of COVID pandemic here. I hope everyone is staying healthy and safe. And as you can see, I'm needing a haircut, as probably many of you are. It's been a couple months since a haircut, and I'm long overdue, my family tells me. So at Concord Orthopaedics, we have a specialty orthopedic practice, and what that means is that we're all focused on one particular area of interest in orthopedics. My particular interest that I'll be talking with you about today is arthritis of the hip and knee and joint replacements of the hip and knee. It's an interesting time, and over the last 6 weeks or so, as you all may know, that the governor and the state and really throughout the country have really put a pause on doing these procedures and what some people term as elective surgeries. What an elective surgery means is it's not life-threatening. So I have this conversation with my patients every day that although your hip hurts or your knee hurts, you're not doing anything harmful by not having surgery, certainly. It's just a matter of tolerance and pain management and pain control, as opposed to patients who have a leaky heart valve or a cancer or an appendix or a gallbladder that is about to burst and can make them very sick. So although it certainly has been a hardship for our patients, and we're looking for that they haven't been able to have these surgeries, and there's been a lot of interest in the news media, perhaps, that some of you have heard. There have been a lot of people advocating that our patients should be able to have hip and knee replacements, not just locally, but from across the country on some of the major media news outlets at night, if you've seen any of those, because it's certainly life-altering. It's, as some of you may know, that they're having surgery or tending to have surgery. It limits your walking, it limits your ability to enjoy life, to work, to go up and down stairs and do daily activities. The reason that we do knee replacement surgery is for pain relief. It ends up being not a normal knee, certainly, but it's typically much better than it was previously. I see a question here from Susan Hofstetter that she had a knee replacement a few years ago, and it sounds like she's having some pain she had a knee surgery about 4 years ago. I'm not sure what knee surgery she had, and that it's sore. So knee replacement surgery typically in the usual scenario results in significant pain relief. Susan, I'm not sure about your specifics, and it'll be hard to address that on an individual level here, but I can give you some generalities in that typically we do knee replacement surgery for pain relief. And once patients have recovered, they typically have much less pain than they had before surgery. However, it's not a normal knee, so to speak. Patients often can describe that it feels tight or thick or stiff, even when it moves well. And a knee replacement is quite different than a hip replacement in that realm, in that our hip replacement is really encased in massive muscles that support our hip joint and an artificial joint. So patients often are not even aware that they've that they've had a hip replacement because there's so much muscular support. And with our knee, if you reach down and feel your knee, you can feel your kneecap. Typically, it's just skin, bone, tendons, and ligaments, so there's not all that muscular support, and so it can feel tight or stiff, even when it moves well. Knee replacements, they can make some noise. They tend to click and clunk a little bit as it contacts, the metal contacts the plastic. Sometimes can be a little gritty or grindy from some scar that can form under the kneecap. And these are just mechanical processes of it. There's typically a scar over the front of the knee, about maybe the length of my pen, maybe a little bit longer, just depending on one's anatomy. And patients can have some discomfort or soreness kneeling on that scar. It's not harmful to kneel on it, but it may be uncomfortable, or patients will often describe that it feels odd. And so I typically recommend that patients, if they're going to do lots of kneeling, get invest in some construction knee pads at your local hardware store, or kneel on a folded towel or a foam cushion. Activities that patients typically are able to do once they've recovered from a knee replacement are typically unlimited walking, swimming, gardening, golfing, hiking, biking, walk on a treadmill, an elliptical machine, an adult exercise class, swimming. These are all fine things. Pickleball is something that patients are starting to get into. Tennis, doubles tennis. Those are all reasonable things to do, but things I discourage patients from doing are the running, jumping, impact type of activities. I think that just puts too much stress on the knees and will destroy the implants. It's interesting in that every step that we take, our hips and knees see 3 to 4 times of our body weight. So running actually imparts up to 7 to 9 times of our body weight with every impact. So that's that's the reason that that I anyhow advise the lesser impact activities. So I see another question. Someone was scared or fearful about having a knee replacement done, or maybe a hip replacement done, or any surgery, and that's certainly an understandable feeling. This is a significant surgery, but it's something that we at Concord Orthopaedics do frequently. We have specialists such as Dr. Fox, one of my senior joint replacement colleagues, Dr. Dion, one of my joint replacement colleagues, and myself and others who our specialty is joint replacement. So you can be confident that we're seeing patients like you all day long, each and every day, and that's what we do. And it's our job. We're not doing a little bit of this or a little bit of that. We're focusing on your specific problem. And that we believe provides you the best care that you can have. So it's not to be taken lightly, and if someone's wondering whether they should have a knee replacement or a hip replacement, they're probably not ready, is what I tell patients, because again, this is an elective surgery, and it's a quality of life issue, and patients, quote, know when they're ready to have it. It's really when patients become limited in a way that they're not satisfied with. They're having trouble walking for exercise. They've been sitting for a while. Hard to get up and get going. After they've been sitting, what we call startup pain, in and out of the car. Sleep becomes an issue. Stairs, they can't do stairs normally. And they're just losing the ability to do the things that they want comfortably and confidently, playing with their children, playing with their grandchildren. These are things that prompt people to consider joint replacement surgery. We certainly have other ways to manage these symptoms. Medicines, over-the-counter medicines can be helpful. Physical therapy can be helpful. Exercise programs, weight loss, as I alluded to, can be very helpful. Cortisone shots or other injections can be helpful. So there are lots of ways to manage the symptoms before it comes to surgery, and many patients have success in doing that. So there are other ways to manage things. So as far as a question regarding how patients follow up and are managed after they have a hip or knee replacement. And the nice thing about this is that we see patients from really all over northern New England, from northern Massachusetts through all of New Hampshire up to Canada, Vermont, Maine, and patients come to us for their initial visit and surgery, but then you can have your local physical therapy back home that's needed, and there's not really frequent follow-up. So usually patients nowadays, these surgeries are becoming more of an outpatient surgery, where a lot of patients will go home the day of surgery who are capable, but most maybe stay overnight, a night in the hospital. Some may require a longer hospital stay. And then they go home and have some therapy and recuperate, and then patients typically will come back to see us in the office about a month after surgery for their initial post-operative visit. So you come back about a month after surgery just to make sure things are healing appropriately. Oftentimes we may see people or patients 3 months after that just to continue to ensure that patients are progressing the way that they want, and some people don't need that visit. And then typically we'll check an x-ray yearly for 2 years, on the anniversary of the surgery, yearly for 2 years after their surgery, to make sure that things are holding up the way we want. Sometimes things can begin to change without patients necessarily being aware of it, and so we check x-rays in that regard. So a couple times of follow-up the first year, and then yearly for a couple years, and then every few years thereafter. But it is important to have routine follow-up. When patients run into difficulty in follow-up or over the long haul is when they've done well for a number of years and haven't been seen, and then they start to have some soreness or achiness, and then something may be happening that it's just put off because patients manage it, and we haven't checked, and there hasn't been an x-ray checked, and then they come back then maybe some years later, and then there's more of a significant issue that may need tended to from a surgical standpoint that could have been tended to in perhaps a more simpler fashion earlier. So the bottom line is it's just important to have a routine follow-up, but it's not frequent. There's another question regarding, hip issues after a knee replacement, and whether patients typically have, hip issues after having a knee replacement. Not necessarily. I mean, it's interesting in that the converse, although not necessarily related, just because you've had a knee replacement does not necessarily mean that you'll have you will have or you will need a hip replacement. That's not necessarily true. But with arthritis, we really don't know the cause or source of arthritis. It's what we call a multifactorial process, meaning there's certainly a genetic component. Many of you who may be suffering from arthritis or have family members who have had arthritis or a knee or joint replacement may have family members who have as well. So there's a genetic component. There's certainly a traumatic component. If you had an injury or prior surgery, that can predispose to the development of arthritis down the line. There's a biochemical component that, just sometimes more hips than the knees. There's the way we were made, the hip joint sometimes can be a little shallow and predisposed to early arthritis. So lots of things can play a role. But just because you've had a knee replacement doesn't mean you'll have a hip replacement. Now, interestingly, I see patients every week that come in along that same line, the relationship of the hip and knee. I see patients every week who come in complaining of knee pain, and it ends up being a hip problem. And it's interesting because the same nerves, essentially, that provide sensation to the hip joint also provide sensation to the knee joint. So sometimes our mind misinterprets where the pain is coming from. So it is not uncommon for patients to have what they think is a knee problem and end up being a hip problem. I see that every week, and that can be hard to explain to patients. But X-rays really show the picture, and when we're able to examine patients and demonstrate to you what joint we're moving and what is producing the pain, then it becomes more clear. There's a question about you know, I mentioned how surgeries have been on hold and when these surgeries may start up again. And, you know, it's really an interesting time. It's unprecedented that these type of surgeries have been on hold or postponed from a governmental standpoint. We're hoping actually we've been doing what we call urgent or emergent cases. So patients who have fractures or a tendon tear or unusual infection or, you know, those type of patient problems have been getting surgery over the last few weeks, but not sort of the garden variety patient with hip and knee pain. However, things are turning the corner, it appears, and it sounds as if next week we're going to be able to start doing some of these of your cases again that you all need, and we're not going to be going full speed ahead as, you know, our typical volume has been over time, but it'll be a gradual build-up over time. But we are going to start doing some cases next week. And so some of you who may be watching, who are patients of ours or patients of other folks, you may begin to see that, and we look forward to helping you feel better. Along those lines, it's going to be a different process, I think, with the COVID situation, and that at least here locally, we're at least putting a screening process in place to test those that are having surgeries to see if they do have COVID-19 virus. Because as many of you may have heard or been aware, that there certainly are many patients who can be asymptomatic from it, have it, and not really know that they have it. And so there will be it looks as if there's going to be a testing process in place that we're going to roll out over the next week or two. Typically, it sounds like about maybe 2 or 3 days prior to the surgery, just so we can have as much information as possible. There are different thoughts on that. I mean, it does give us that information on that moment in time, but doesn't tell us what happens over the next few days. So, you know, we don't really test everyone with to see if they have HIV or those type of things. But that's, you know, this is an evolving process and a new unprecedented time, and that's those are the immediate plans, and that'll roll out over the next couple weeks. And how long that goes on remains to be seen as far as the testing. You know, much of the difficulty with elective surgery and doing surgeries, and that hospitals across the country have seen, is not so much the risk of surgery, but more of the supply of what we call personal protective equipment. So it's the masks, it's the gowns, it's the use of those things that have really limited these surgeries as much as anything. And I think the same thing will be that way with testing as well. And you may hear that on the news. There's, you know, how much of a supply of the tests are there, and what kind of supply remains to be, or production that these companies can make will in some ways determine how long the testing goes on, or if it's something that's able to be done over the long term. So there's a question about injection and not helping for capsulitis. So I'm not sure exactly what you're referring to. Sometimes if that's an injection for the hip, you know, cortisone shots, as I mentioned, are one way that we can manage the symptoms of arthritis, whether it be for really any joint. It's not a cure for arthritis. It's just it's a pain blocker, really. It doesn't regrow the cartilage or anything like that. It's just a pain blocker. And in my experience, and in most, I think, orthopedists' experience, shots for the shoulder or the knee tend to be more predictable than shots for the hip. So it's hard to know if you have a specific issue or something hasn't worked. You know, we'd be happy to evaluate you further in the office, but it's hard to know a specific question such as that. And of course, there can always be other things going on. As I mentioned, that hip problems can give patients knee pain. Other anatomical issues can give patients hip pain, and the back problems, arthritis in the back, or a disc protrusion, or nerve being impinged by an arthritic spur can give patients some hip and leg pain as well. There are also, everything's not necessarily related to arthritis either. So, you can have a tendonitis or a bursitis, soft tissue pain, or just a muscle strain or contusion. Sometimes stress fractures of the pelvis can mimic a hip problem. So lots of things can contribute to that. And if a cortisone shot for the hip, although it may not give lasting relief, it usually does give some transient relief, even if it's for hours or a couple days. If it just didn't give any relief at all, then we may want to search for other sources. Or again, maybe the medicine didn't get exactly where we wanted it to. These are all situations, and it's hard to know for sure about your specific situation. This has been interesting. We're getting more familiar with being on Facebook, or we've been doing lots of telemedicine over the last number of weeks, in which we're trying to adhere to the social distancing recommendations from the CDC and Dr. Fauci that we've all seen on TV, and so we've really, although our office is open for urgent and emergent things, and we're gradually expanding our office capability, still keeping in mind social distancing. So those of you who have been in our office previously on really crowded days know that there can be lots of people and it can be crowded, but we're adjusting schedules and taking waiting room recommendations. Our flow in office organization is somewhat different, so that we're adhering to these social distancing recommendations, and I foresee that being the case over the long haul. All patients that come to our office, we test your temperature, we ask you some history questions about at-risk procedures. Typically patients have been screened often the night before as well. All of our staff that comes in, we ourselves are getting temperatures checked twice a day. We're all wearing masks. You as a patient who would come in would be wearing a mask. Our staff is, instead of waiting in the waiting room so often as many of you may do, we're limiting waiting room access, and patients are coming into their individual exam rooms and waiting in the exam room more, as opposed to being in the waiting room with more other patients. And so that's been helpful. Everything's being cleaned frequently, and so we certainly are taking all this seriously. But things look like they're going to open up a little bit, which we're all excited for, and we're excited for you to be able to enjoy the benefits, because we know how difficult these issues are when you have sore knees and sore hips and you can't get around and you just want to get this taken care of. So again, another question about when we'll be able to do these surgeries. We're going to be able to start to do these surgeries next week on a more graduated basis, and hopeful to expand that accordingly as the weeks go on. So it looks like the door is beginning to open. And as far as determining who gets the elective surgeries when it starts, I mean, I think we've had lots of patients who have been postponed. Over the course of the last 6 weeks. There's a whole list of patients, but there have been patients who are already scheduled for May and June. Now some patients, and some of you watching, may have decided to wait on your surgery. Some want to proceed as soon as possible. Everybody has a different opinion on this, and so it's really not feasible for us to, unfortunately, for those patients who have been displaced, to be put necessarily back at the top of the list again, because just from an office functional standpoint, that would require rescheduling all these other people. So we're going to have some expanded operating room time. Certainly some people have postponed their surgery, and people will be able to be slotted into slots that patients have postponed. But it's just from an operational standpoint, it's you, unfortunately, who have had surgery postponed, know how difficult that is, and to postpone others and then reschedule, it's just a scheduling morass that's just not feasible to do. So, trust that we have lots of, we're going to have lots of operating room time available. Those of you who will be candidates for outpatient surgery in the surgery center setting, where you don't even have to come into the hospital for surgery. We will expand that as well, and that will decrease the backlog, not only for those of you who are candidates for that, which we've been doing, for a few years on a regular weekly basis. This isn't anything new for us, but that will decrease the backlog for those of you who are candidates for that, and it will also decrease the wait time for those who are better served by having it in the hospital setting. So that's sort of a long-winded answer, but it continues to evolve, and have faith that our staff, which is great and really doing yeoman's work over the last 6 weeks, are doing the best we can. And it's a moving target. Things change. Things change every day, really, and not only for you as patients, but for us as here in the office on based on what kind of guidelines and such we're given. Another question about injections. Injections are a popular topic today, about getting injections in the office and how often can that be done. And there's some variation to that, but typically for cortisone injections, whether it be for the knee or the hip, and my experience, I recommend that patients not have them any more frequently than about every 4 months. The more shots that one has, the less they tend to work over time. So as long as you can spread it out, the better it is for you. Again, cortisone is not it's not solving the problem. It's just a pain blocker. And what it does is it blocks one of the chemical processes in how our nerves appreciate the pain pathway, what we call prostaglandins. So cortisone in the soft tissue, sometimes in the hips, we'll do shots in the hip, not necessarily in the joint, but on the side of the hip over the bony prominence called the greater trochanter for bursitis or a tendonitis. And some of you watching may have had those type of shots, and that can be helpful for patients who have really discrete, exquisite pain, but it's not. But really, the mainstay of treatment for that situation is really physical therapy. It's stretching of those muscles and tissues. It's modalities where a physical therapist can do some ultrasound and what we call iontophoresis and techniques just to break up that inflammation. Although cortisone can be helpful for pain relief in that situation, it also can be damaging to the tendons and such around the soft tissue. So an injection here or there about the hip and the tendons or the muscles of the hip can be helpful, but too many can also be detrimental. So we do that periodically, but with caution. There's a question about X-rays being done at the same day of the appointment, or do they have to be done ahead of time or afterwards? And we're happy to say that we're really a full service office here at all of our offices. Some of you may or may not know that we have satellites really across the state. We have our main office here in Concord, a large office in Derry. We have a satellite office in Windham, and we have a satellite office in New London as well. And I would anticipate that as time passes over the years that we probably will have more as well. Our goal is, as I'm coming to you in your home today in a setting that hopefully is more convenient for you, and trying to keep you out of the medical morass that's going on with the virus situation, we're hoping to continue to provide you more local care. So at all these facilities, all of our offices, we are able to obtain X-rays at your appointment. You do not need to have your primary care person order X-rays before you come to an appointment with us. It's very easy. We can do it here at any of our offices at that time. We also have MRI on site here in Concord. There's a physical therapy office in our office here in Concord. We have 2 surgery centers. There's one here in our Concord office, and we are anxiously looking forward to our new surgery center across the street here in Concord as well. We will still be seeing patients, as those of you who've come into our office, in the office here in Concord. This will still be our anchor for patient visits, but we will be doing our outpatient surgeries that traditionally have been done downstairs here in our Concord office across the street in the new building that's going up there. It's going to be a state-of-the-art facility. It will allow us to do and allow you to have outpatient surgeries with spine surgeries, total joint surgeries, any surgery that you can imagine. It's going to be a great facility, and we are anxiously anticipating that opening, and that will probably be sometime probably after Labor Day, but our goal is within this calendar year. We also have a surgery center, maybe, which many of you in the southern part of the state have experienced at our in Derry as well, just a couple doors up from our Derry office, and that has been a great addition as well, and many of our patients have benefited from that, and that's where we have been doing our total joint surgeries today that are outpatient bound. So I see someone who lives 100 miles north. It's fantastic that that we can see you on today, live here, and save you a trip. And thanks for joining us. And we can certainly, make sure that you get X-rays when you schedule your appointment here at that time. We do have, in addition to our satellite offices. Some of you may know that we have what we call an acute injury clinic or a walk-in clinic for orthopedic needs. We are still open. Our goal is to try to serve you better. We're trying to keep those of you with bumps and bruises and sprains and relatively straightforward orthopedic needs out of the emergency room where the sick people are, and try to have you in our office again with appropriate social distancing. So it's called the Acute Injury Clinic. You do not need an appointment to come in to see us. For that, you can just walk in, and these are for acute sprains or falls and your wrist or those type of things. Our updated hours for that are currently 9 a.m. to 4 p.m. Monday through Friday, and I would anticipate that those will, as things loosen up here, hopefully over the next couple of weeks, will continue to expand back to our more normal hours. And our website certainly will have updates on that you can address. Our website's a great resource for information for all of you. There's a lot of great patient education on there, as well as office hours, information about your surgeon or physician assistant or nurse practitioner who you may be seeing, and I would encourage all of you to visit that. And it's concordortho.com is our website, CONCORD ortho, ORTHO.com, and that's all one word, and it doesn't have to be capitalized or anything such as that. Someone had a question about AVN. What is the diagnosis of AVN? And AVN is an initial, or initials for avascular necrosis. The most common site of that is the hip or the femoral head. I have a model of a hip here today that I can sort of show you. So here we are in front of us. This is all, as I was referring to earlier, these are all the muscles that support the hip joint on the, this is the right hip as you're facing me perhaps, and this is the left hip that we can see a little bit better. And so remember, the hip's a ball and socket joint. So here's the thigh bone, and here's the ball of the hip joint called the femoral head. It's connected to the femoral head, what we call the neck. And then the ball articulates within the socket, what we call the acetabulum. And bone, we may think of bone as, sort of just a chalk-like substance, from eating steak or what have you, but it's not just a chalk-like hard, inert substance. It's a viable living structure. It has a nerve supply. It has a blood supply to it. And what avascular necrosis means is it's an interruption to the blood supply of the ball of the hip joint. And the blood supply to that ball is very tenuous. The blood vessels are very small. They can be, if there's a fracture or a fall or some unusual maneuver, they can be damaged. Bo Jackson, who maybe some of you have heard of, who was a professional athlete, that's what ended his professional sports career, was avascular necrosis. He was tackled in a game, had a subluxation or injury to his hip that wasn't initially recognized, and the blood vessels were compromised, and the ball of his hip joint then essentially dies. The bone cells die. Our body tries to repair those damaged bone cells by removing the damaged bone cells and then going in and rebuilding it with new bone cells. But in that process, a pothole can develop, and the ball can collapse, and then it's painful as arthritis. So that's the most common site of osteonecrosis. How patients do with that really depends upon the size of the area of involvement. Sometimes if it's a small area of involvement in the ball, patients may have some acute pain, but then the symptoms may abate or get better. If it's a bigger area involving most of the ball, then that tends to be an ongoing, more prevalent, persistent problem, and typically results in a hip replacement most often. But if it's a small area, imagine an analogy I like to use is like a freshly paved road where there's a small pothole in the road, and you're driving your car across it, and you might skim right across that small pothole and not even notice it. So it may have been painful when that initial pothole occurred, but then it can perhaps resolve, and you go on to not notice it. But if it's a bigger pothole, then your car wheel hits it, your coffee spills all over, everything spills in the car, and that's analogous to more of the ball being involved and more of a problem that becomes more persistent. So hopefully that was helpful. So there's a question here from Rosemary about what's the criteria for who has outpatient surgery versus inpatient surgery. That's a great question, one that continues to evolve over time. Medicare now has really classified knee replacement surgery as outpatient surgery, meaning at most really a overnight stay in the hospital or surgery center. And then patients go home typically within 23 hours. A lot of factors go into that. Some insurance companies grant patients the benefits of having of being able to do joint replacements in a freestanding surgery center where they don't even have to come into the hospital. Other insurance companies don't, and it can vary from location to location or plan to plan. Certainly one's overall health plays a major role, probably the most important role, other than if you're able to do it from a financial standpoint on your end, if the insurance company will support that for you. But ultimately, it's your health. Patients obviously need to be healthy and good health, need help at home. Patients who would not be good candidates for the outpatient setting, going home the same day, or someone who has more medical problems, they are carrying some significant extra weight, they've had heart problems, heart attack, they take blood thinners, diabetes that is poorly controlled, they don't have help at home, nobody lives at home with them, and they have lots of stairs that they have to climb up and down, and those would be some examples of patients that are not good candidates for the outpatient setting, or someone who's has some underlying neurologic issues. They're older and maybe not as active as they once were. So those are some examples of who may or may not be a candidate for outpatient setting. And Carol is asking whether knee replacements can be done at the surgery center in Derry, and they certainly can be, and they are, and have been for a couple years, and that's been patients typically have been quite pleased with their experience there. And that's a situation when, what happens when patients have an outpatient surgery where they don't even come into the hospital, they're done in the surgery center. Patients, we have a whole protocol spell it out for that. So we want to make sure that you, the patient, are comfortable, your family's comfortable, as it can be a nice offering for you. But what we do is we have you go to meet the folks at the facility. You go meet with some of our nurses. Sarah goes over everything with you at the facility so that you're comfortable with it. You know where it is, the expectations of what's going to happen that day. We have you meet with physical therapist, and this is about a week or two before surgery. We have you meet with a physical therapist that same day that you have a tour of the facility, where you do some preoperative teaching. You learn how to use crutches or a walker. You go up and you're shown how to go up and down stairs, get in and out of a car. Just do everything that you need to do safely. Because we want you to learn that. We don't want you learning everything the day of surgery, because I've been a patient myself, and there's just so much information that gets thrown at you that we want you to learn it ahead of time, so you're not learning everything that same day. And then after that same day that you've had a tour of the facility and that you've had physical therapy, then typically I want to meet with you again with your significant other, or whoever is going to be helping you after surgery or be with you. We want and ask that they go with you to these appointments, because everybody has to be on the same page, and we want expectations to be met, and that's really the key thing, is to set expectations, and you don't like surprises, we don't like surprises, and that's really the key there. And then the day of surgery, what happens is typically patients come in about an hour and a half or 2 hours before surgery. Surgery roughly takes about 2 hours, sometimes shorter, sometimes longer. Patients there are two different areas of a recovery room. The initial area of the recovery room, you're just sort of coming to from anesthesia for about an hour and a half, and then you transition to a second area of the recovery room where you sit up in the chair, you walk down the hall, you go to the bathroom, a physical therapist comes over and makes sure that you can do stairs, and then you're able to go home. And that's really it. So that's the typical course of the day. Patients often have concerns about I can't do that. I'm afraid to have outpatient surgery. The pain is going to be, how am I going to manage that? And we have developed a protocol for pain management that is very effective for patients, whether you're in the hospital or at home. Safety is really the key to being home. You can take medicines for pain at home or in the hospital, and I'll just tell you, I'll review a little bit how we manage your postoperative pain. So when patients go home, we're maximizing their non-opioid medications. So typically I have patients take Tylenol 1,000 milligrams 3 times a day when they go home, an anti-inflammatory such as meloxicam that they take midday, and a medicine for nerve pain at night called Lyrica. And these are all non-narcotic, non-opioid medicines that we have patients take every day on a regular schedule, around the clock for the first few weeks, and that really helps quite a bit. And then patients typically would also go home perhaps with a prescription of an opioid type medicine, which you might need for maybe just a couple doses or a day or two if it's a hip replacement, or a few days or maybe a week if it's a knee replacement. And that regimen really helps quite a bit, and we've really seen how patients need much, much less in the way of these opioid type medicines with this protocol. And that's really important, because opioid type medicines like names that you might be familiar with, like Vicodin or Percocet or oxycodone or Dilaudid or hydromorphone or tramadol, they're opioids. They have significant side effects. They make you nauseated, constipated, make you feel a little fuzzy. They can be addictive, and so a lot of times they end up causing more side effects than they help. So we've really switched over the last few years to this, maximizing the non-opioids, and that's really made a difference for patients. And we do things during surgery as well, and even before surgery, which are helpful. So when patients, even when they come into the surgery center setting or the hospital setting, even before surgery, we give you preemptive pain medicine, typically an anti-inflammatory and Tylenol before surgery even starts. During surgery, we'll inject the tissues with numbing medicine like a dentist would when you're having dental work, and whether it be for the hip or the knee, and that really helps quite a bit for the first day or day and a half or so. And sometimes our anesthesia colleagues will assist with nerve blocks, which is again another way to administer some numbing medicine before surgery. So those are all ways in which we help patients manage their post-operative pain, which has been really very helpful. And I think that's really been, in my experience, the biggest game changer, so to speak, over the last number of years as far as the improvements in patients' recovery. There are lots of different implants or techniques or instrumentation that can be used to perform a surgery, and they all have some role. But the thing I think that has really changed the most, particularly for knee replacements, is pain management for patients, and that has really enhanced recovery, and people are just doing so much better, so much sooner. With that. Now, not to say that it's an easy recovery. The first 6 weeks, certainly after knee surgery, are a lot of work. It's stiff, it's tight, it's sore, you're fatigued. You have to take the medicines. It's and if you do that, then it comes around, which is different again than the hip. The hip recovery is typically easier. It's typically less painful. Not that it's pain-free, certainly. That's not realistic, but it's typically recovery from hip surgery. The pain is typically pretty well tolerated by patients, and things move along much quicker typically with hip surgery. Let's see. Sarah has a question about an age minimum to be able to get a knee replacement. That's a great question. There's not really, at least in my practice, there's not really an age that where all of a sudden you have to hit that age to be a candidate for a knee replacement. And on the opposite side of that, there's not an age that you're too old for a knee replacement either. So, everybody's different. Obviously, younger patients may have more options for knee replacement, to manage things. The younger we are, the more active we are, the more wear and tear goes across the implant and prosthesis, and the more likely it is to need to be redone. And redo surgeries are just not as predictable as first-time surgeries. So we're likely in a younger person, and by that I mean in their 40s or 50s, to really try to maximize their non-operative approach and really just learn how to manage with some discomfort, that although it's uncomfortable and sore, for it to be manageable. If we've done all the things that we've talked about with braces and shots and medicines and weight modification, and the x-rays, of course, and everything add up to corresponding to that being the problem of arthritis, then we're not necessarily going to continue banging our head against the wall and get frustrated. But at some point, if it's really impacting patients in a way that's just not satisfactory, then I'll offer those patients knee replacements, and they do quite well. But it's really just a matter of expectations. And similarly, on the opposite age range, patients who are older, everybody is a different physiology, meaning I have seen patients who are 85 who really are in their 60s as far as their functional status, and conversely, I see patients who are 60 who, physiologically have a lot more medical problems, and they're similar to someone in their 80s. So there's really not an age range, so to speak, but we just take everything into consideration. And it comes down to, two different types of patients. So there's the, once the patient starts considering it, there are two different types of patients, basically. There's the patient who comes in and says, this is bothering me, and I don't like the way it feels, and it's sore, and I don't like it, but the last thing that I want to do is go through surgery. And that's fine. As I mentioned at the onset here, that this is an elective surgery. It's no harm is coming to you by not having a knee replacement or hip replacement, but it just becomes a quality of life issue. And if you can manage it with medicines, activity modification, braces, etc., then certainly that is fine to do. And then there's the other group of patients who come in and say, this has been going on long enough. I know it's not going to get any better, and I just want to have it fixed, so to speak, so that it has the potential to be as good as it possibly can for me. And those patients, want to have the surgery. So it's really a personal decision, and my job and our job is just to really help counsel you as to what your options are, share our experiences, recommendations. I see patients every day who I tell they certainly don't need a knee replacement, or I wouldn't offer them a knee replacement. It's just not, or a hip replacement. It's just not what they need or what they would benefit from. And then on the other hand, there are patients who suggest, I think that you've done everything and that it really could help you. So we're trying to work with you and help you do what's best for your individual situation. There's a question here about what hip and knee replacements are made of, and so hip and knee replacements are, they can be made of a variety of things, but basically what a knee replacement is, and I had a model of a knee replacement and I didn't, I left it in the other room unfortunately, but what a knee replacement is, I can show you a model here. This is a knee, a model of a knee. Thigh bone is on top, the shin bone's on the bottom, here's the kneecap. And if we just pull the kneecap aside, what you see demonstrated here on the light blue is the normal articular cartilage, which is the protective cartilage cushion of the knee. And you can see on the brown or greenish areas, that's where demonstrating where the cartilage has worn away. These discs that you see here are sort of rubber disc, that's what we call the meniscus. And this cartilage, once it wears away, it just can't be rebuilt. Our body can't fix it. It doesn't have a nerve supply. It doesn't have a blood supply in order to repair it. So when a knee replacement is done, what we do, and it's easiest to show you from the side here, so what we do is we remove a few millimeter shavings of the top, end, and bottom of the knee replacement so that that damaged cartilage and bone is removed. And then it's covered with a C-shaped metal cap like my hand, like so. That's just a few millimeters. It's about 9 millimeters thick all the way around, which it may be made out of chrome cobalt, a highly polished metal alloy, or titanium. There's another one that's sort of ceramicized, if you will, oxinium. There are a variety of different ones that can be used. They all work fine. And then that covers it. And then on the top of the shin bone, again, a few millimeter wafer of the damaged cartilage and bone is removed from the top of the shin bone so that a flat metal cap covers the top of the shin bone. And then there's a plastic cushion that goes between. It's about a centimeter thick in size. In the kneecap, typically in the United States, we resurface the kneecap, meaning the cartilage that's damaged on the undersurface of the kneecap is removed with a few millimeter wafer shaving that's removed, and then the undersurface of the kneecap is covered with a plastic button. So that's a knee replacement. Hip replacement. This model is really very helpful. So here's a model of the hip. This is the hip that I showed you before. So the hip replacement, the ball of the hip, normally, again, you see the blue covering on the end. The red is the damaged cartilage, so that is removed. And then, so the thigh bone is, left like so without that ball on it. And then there's most typically a titanium stem like this. It's usually, maybe about the length of a pen or pencil. And you can see how we prepare. The bone is a tube, and so you might be able to see how this bone has been prepared so that this fits very tightly into the tube of the thigh bones, fit in very tightly typically, so the bone will actually adhere to that. The bone will grow right onto it. This surface typically is a really rough surface. It can have pores on it, sort of like an SOS pad that the bone will grow right into over about 2 months or 3 months. And then you can see this pink ball. The pink is a ceramic ball that replaces the damaged ball that was removed. And so that's the part on the thigh bone with the hip replacement. And then in the socket, so here's the pelvis, here's representing the cartilage cushion of the pelvis that's been damaged. So that is smoothed away, really. It's not really removed, but it's just smoothed down to a smooth surface. And then again, here's a titanium shell with that real rough surface on the back that is inserted very tightly into the socket. And perhaps you can see the gray or the light white colored plastic liner that snaps in, which becomes the new cushion of the hip joint. And let's see if I can figure this out. And then so that becomes your new hip, such as that. So it becomes a new ball, which may be ceramic or metal, and it rubs against that plastic liner. So that becomes the new hip joint. So that's what typically they are made from. as far as, other questions, just to let you know, I'm pleased to be able to, come to you today live from Concord Orthopaedics, Facebook Live, which has, been really interesting for me to be with you today. I'm not sure if any of you have picked up any old hobbies, over these last 6 weeks in this time of sort of quarantine or social distancing and such. My family's been doing some puzzles, which we haven't done in a long time. Our poor dog is getting walked more than probably ever has before, and has lost a lot of weight. And the pads on her feet, I feel bad for her. My wife has her out walking all the time, and I'm probably going to get a haircut for my kids this weekend. So it's been an interesting time, to say the least, but we've been pleased and proud and happy to maintain our office open for you, to be here for you, and we're looking forward to continue to expand our services to you over time. And certainly feel free to call any time for us. As hours that I mentioned, we are open and looking to expand things over the next few weeks as things open up, and we're really happy to be able to start doing more of these, quote, elective surgeries. I know so many of you and those of us who have been through it ourselves wouldn't necessarily see them as elective surgeries, but it is what it is, and we're going to be really happy to get you back to doing what you want to do. So take care. Have a great weekend. I've enjoyed being with you, and stay well.